Hello everyone, my name is Emily Cossack and I'm the Knowledge Manager for the Canadian Institute for Public Safety Research and Treatment. I want to welcome you to today's session, which we are calling a PTSD crash course. Before we get started today, there are just a few housekeeping items I want to go through. All attendees are in listen-only mode. This is to limit feedback and noise throughout the presentation. Today's session is being recorded. You'll be sent a copy tomorrow, so if you miss anything, you can watch it again. The GoToWebinar launch window can sometimes be blocked by some organizations, so if you're having trouble hearing or seeing, you may have to join us by phone. Lastly, we will be looking for audience questions at the end of the session, so please send us your questions through the questions block throughout, or you can raise your hand and I can unmute you to ask your question during the question period. Now I'm going to introduce you to our speaker for today, and that is Dr. McElheran. She's a clinical psychologist from the Wayfound Medical Group, and she is chair of CIPSRT's clinical subcommittee. Sorry about that, Megan. Thank you so much for being here today.
Thank you very much, Emily, for having me. My pleasure. Okay, hold on. Let me just make sure I'm doing that. So my screen, you can see my screen okay?
Yep, I can.
Okay, so you see my slides?
I can, yep.
Okay, excellent. Thank you so much.
No problem.
Well, thank you to CIPSRT and to all of you who are in the audience for coming to our PTSD crash course webinar this morning. As Emily mentioned, I'm a clinical psychologist. I'm practicing in Calgary, Alberta, and have spent about the last 20 years working in military and first responder mental health. You know, I started my career working at the National Center for Post-Traumatic Stress Disorder in Menlo Park, California, and have worked in the operational stress injury clinic here in Calgary and have been in independent community practice since 2011. And so in addition to talks like this and program development and sitting on committees and things like that, I still have an active caseload where I work with police officers and firefighters and paramedics and so on and so forth in a frontline kind of capacity. So I'm really excited to be here and to be talking about, you know, post-traumatic stress disorder and its relevance for public safety personnel, and, you know, really to try to share the best of what we can do in the sort of 45 minutes that I have with you to just, you know, kind of reorient and sort of normalize and level set on the information that's out there and the information that you have. So you can either support yourself or support the members that you're working with in a different and perhaps enhanced fashion. So this is a really big subject area that we're going to try to condense into, you know, a fairly high level of lecture here for the next little bit. I am always happy to connect with people after these types of webinars. I think, you know, we have a national problem on our hands, and so it's nice to make national connections. So my email's at the end of this presentation, and again, I just encourage you to reach out if you do have questions or any comments or follow-up after we're done today. So what I'm going to be talking about today is really starting with what is post-traumatic stress disorder. Emily had asked me just to kind of do a bit of a crash course, really focusing on almost like a back to the basics, right? I think that there is lots of terminology kind of out in the sphere working with PSP nowadays, and I think it's always really useful for us to be able to just, come back to basics and really, you know, talk about terms, talk about, you know, what do we actually mean when we use the term PTSD, what is its relevance as it pertains to public safety personnel. So that's really going to be the focus of today. So I'm going to talk about PTSD and generally speaking what it is. I'm going to talk about some of the common signs, the symptoms, the diagnosis, some of the unique contributors to post-traumatic stress disorder for public safety personnel, talk a little bit about treatment, just so you know, for you, those of you who may be supporting PSP, you have an idea of what some evidence-informed treatment options could be. So you're making sure that your members are getting what they need. We'll talk a little bit about myths and a little bit about what to look out for when you sort of see, you might see changes in people that are around you, whether in your personal or professional life. So those are kind of the topic areas we're going to focus on. Again, this is, you know, we could spend a whole week talking about this subject, so this is really kind of a teaser and intended to be so. And so, as I said, please do feel free to connect with me and reach out afterwards. So, post-traumatic stress disorder. I wanted to start just with, you know, what is PTSD, right? So post-traumatic stress disorder is the term that we use for a diagnosis that is contained in our Diagnostic and Statistical Manual for Mental Disorders, the 5th edition. it is a diagnosis that is accompanied by a predictable set of symptoms. So I'm going to talk about the actual diagnostic criteria in a moment. What I find is that PTSD tends to get sort of thrown around as a bit of a label or a descriptor, and sometimes I find that it can be used or understood in a way that may not actually be 100% accurate or relevant to, what it is actually intended to encapsulate. So post-traumatic stress disorder is the diagnosis. It is, what we would get to after engagement in the psychological assessment process, where we would be a mental health professional, a psychiatrist, a psychologist, whomever would be confirming the presence, the severity, and the frequency of a certain number of symptoms that are consistent with this injury of post-traumatic stress disorder. And I'm going to speak more about the injury aspect to that in a moment. So, one of the things that I think is important for us to know kind of in the field as a whole is that up until fairly recently, 3-4 years ago, something like that, in the 4th edition of the Diagnostic and Statistical Manual, sorry, it's hard to get that out, the DSM, up until very recently, PTSD was actually categorized as an anxiety disorder. And when we came to the 5th edition, there was a whole bunch of work that went into recategorizing essentially PTSD into its own set of diagnoses called stressor and trauma-related disorders within the DSM. So that, anyone who was diagnosed with post-traumatic stress disorder more than, let's say, 4 or 5 years ago would have been diagnosed based on the former criteria. And the criteria now in DSM-5 are quite significantly different. So that's something that we want to understand, is that, PTSD from a diagnostic perspective is now captured as an entirely different set of trauma and stressor related disorders, in addition to things like acute stress disorder, adjustment disorder, so on and so forth. I always like to make this point. When we had PTSD in DSM-4, we had something like 74,000 different symptom combinations that could lead to a diagnosis of PTSD. When we recategorized PTSD in DSM-5, we now have something like 217,000 potential symptom combinations that can lead us to the same diagnosis. So, right, you may be reacting to that. I certainly do, and did when I learned about that, because what that tells us is that there's many, many, many different ways that somebody who's experiencing symptoms following exposure or exposures to potentially psychologically traumatic events, there's a lot of ways that people can get to ultimately the diagnosis of PTSD. Just means that there's a ton of variability in terms of how people might present with PTSD symptoms after one or more exposures to traumatic events. One of the things that's really important for us to know about a diagnosis of post-traumatic stress disorder is that unlike other diagnoses in the DSM, so depressive conditions, other anxiety disorders, PTSD must have exposure to an external event in order to influence the onset of symptoms. So, other diagnoses can develop from what are called endogenous mechanisms, right? Things that happen from sort of within us, whereas PTSD must have an external stressor, an external threat that occurs in order to lead to the onset of symptoms. So I think, again, when we're talking about using terminology around injury, and we're going to be talking about, attempts to destigmatize this condition and the attempts that are being made in that, I think that's an important thing for us to keep in mind. There's a lot of there still is a lot of narrative that PSP have around their own weakness and deficiency and inability to cope with the rigors of the job, and that's why they've developed these symptoms. And I think it's really important for us to just know that that's not the way PTSD works. PTSD is a syndrome or a set of symptoms that can develop because there has been exposure to these really potentially life or other threatening events in the environment or in the occupational world. Okay, so what goes along with that, and something that I really like to sort of start off with and emphasizing, is that if we have an exposure to something that could potentially threaten our lives or threaten the life of somebody who's in front of us, if we're witnessing some kind of tragedy or horrific event that's happening, our brains, our nervous systems are designed to have a whole physiological, cognitive, emotional set of responses to that exposure, right? So the reaction, what we sometimes refer to as a limbic response to stress, that is actually perfectly normal, appropriate, necessary, needed, and has been absolutely influential over our survival as a species, right? So again, we want to neutralize and poke holes into this idea that the response is in some way assigned a deficiency or not being strong enough or competent enough. In fact, quite the opposite. The healthy, typical, natural, normative thing we want to see is that somebody actually has this type of response in relation to a traumatic stressor. Now, let me be clear. I mean, people go through training, they go through the things that they need to build up to be able to be successful as a PSP, so that when they come to the scene of critical incident, they can do their jobs. And there's nothing wrong with that. But I just want to underscore the point that we are driven by a whole set of biological and neurological processes that are designed to have that response occur, okay? So a stress response in relation to a stressful situation is totally appropriate. One of the things that I talk about with the PSP folks that I work with all the time is that, when horrifying things happen, the natural reaction is to feel horrified. When something that is morally injurious happens and that, evokes a feeling of despair, that's a perfectly natural response. What starts to become problematic is when we interpret or judge the reactions that we have to critical incidents or operational stressors, that then leads us into a pattern of suppressing or denying or ignoring or trying to change the reaction that we've had. So, right, PTSD must have exposure to an external stressful event. Exposure to a stressful event triggers naturally a whole series of responses within our nervous system and within our biology to help us cope with and ultimately survive whatever that stressor or trauma is. And that response and the incumbent emotions that go along with it are perfectly natural. That's absolutely what should and frankly we want to have happen, because that really is how we're designed as human beings. And then we have to talk about, okay, well, so what happens that gets layered in to interrupt the process of being able to work through and move beyond that response once it occurs. Okay, now, there actually was some really interesting research that came out. Now, this would have been like in 95, 96, something like that. It was out of the US that really looked at, what are the rates of exposure to potentially traumatic events, what we call a criterion A stressor, compared to the actual onset of symptoms of post-traumatic stress disorder. And what was found, it's a study by Kendall Tackett is the person's name, was that actually most of us probably at some point in our lives are going to experience exposure to the type of traumatic event that could lead to the onset of symptoms of PTSD. But actually, from an epidemiological perspective, the number of people, the percentage of people who go on to develop PTSD within the general population is actually relatively low, right? So, we're all going to go through trauma probably, but actually a relatively small number of us are going to go on to develop post-traumatic stress disorder. That was really influential in the field of PTSD research and treatment, et cetera, because it actually helped kind of shift the mindset or the understanding that it's not necessarily just exposure to trauma that is the factor that can lead to the onset of symptoms of PTSD. Of course, like as we've said, exposure is a necessary part of post-traumatic stress disorder. However, it's good for us to know that there's actually mediating factors. We as a human species seem to have natural ability to recover or process or move through and sort of recover after a traumatic event happens. And we have actually probably a lot of ability and some very natural processes to work through traumatic events when they occur so that we don't end up developing symptoms of post-traumatic stress disorder. That's really important from a culture perspective within PSP organizations. It's really important for us to understand as treatment providers, because what it tells us is that when people do go on to develop PTSD, and in our Canadian PSP population, we're probably anticipating somewhere around 25% of Canadian PSP are developing symptoms of post-traumatic stress disorder, really, really high compared to general population, which is around 2.3%. what it tells us is that something is interfering with the natural process of recovery, right? If we know that we actually have these embedded mechanisms within us to recover from traumatic events when they occur, well, then something is happening that is interfering with that process in PSP populations where the rates of PTSD are that much higher. Certainly, we know it's a matter of exposure, right? I mean, we're talking about with the typical, police officer, or paramedic, or firefighter, corrections officer, communications, whatever. We're talking about hundreds and hundreds and hundreds of exposures, over the course of a career. So there simply is a numbers game in this, right? That PSP are generally speaking being exposed to trauma at a level that is just, completely foreign to sort of civilian or general population, right? But additionally, and one of the things that I talk a lot about, a lot of program development I do, is really around organizational culture within PSP departments, because, there has been a historical sort of trend towards this sort of stoic, what I consider to be a bit of misinterpreted stoic philosophy, this idea that you should just be able to sort of endure and withstand and sort of deal with it because it's part of the job, right? There seems to be something about that culture and potentially that attitude that, again, contributes to the interfering of the natural process of recovery, right? So one of the things I want you to take away here is that we know, that most PSP are going to experience repetitive exposures to potentially psychologically traumatic events, PPTE we call them, right? But the exposure in and of itself is not necessarily sufficient in and of itself to lead to the onset of symptoms. It is a necessary component, a necessary, part of the diagnosis, right, is the exposure. But assuming there is a helpful and supportive social environment, assuming that there is time and space and support given to the person to have a natural process of recovery, it's not necessarily that the exposure itself is always going to lead to the symptoms of PTSD. I actually think that's a very hopeful message, right? Because I think that really helps us to understand that there's probably multiple ways that we can come at and try to tackle this problem of PTSD and operational stress injuries within PSP organizations, right? Because if it's not just the exposure and there's other things, well, there's other things we can work on, right? Trying to solve the problems of the world and have there stop being trauma in the world, that's a bigger elephant to try to eat, right? But knowing that there's things that we can actually do from an organizational, from a peer perspective, even within ourselves, to work through and process and stimulate the natural process of recovery. Again, I think that's a very hopeful message, right? We certainly know, and this is some of these interventionist types of pieces, that, how somebody is, where they're at, just in the trajectory of their career, how much recent trauma exposure they've had, how stable their personal and social relationships are. There's a lot of individual factors and contextual variables that can really influence how a traumatic event is experienced and potentially processed or not. And I put here operational versus organizational stress because we actually know, we've got some recent research, and I can provide links as required. We have some recent research that does tell us that, when we're looking at what are the things that are contributing to mental health problems in our PSP groups, the organizational factors are frankly just as significant as the operational ones, right? So certainly exposure to critical incidents, pediatric fatalities and sudden deaths and what have you, of course, these have the potential to be really influential over psychological decline. But the organizational factors, resource shortages, budgetary concerns, invalidating social environments, maybe some, perhaps toxic dynamics within a workforce, lack of perceived support from supervisor to frontline. Whatever it is, those organizational stressors are identified as very, very significant over both maintenance of psychological health and also recovery from psychological injury once it's sustained. So, again, I sort of mentioned one of my sort of areas of interest right now really is looking at doing more work at the level of leadership and with organizations as a whole, because I think, there's an understanding that some of the historical cultural variables within PSP organizations continue to need to be addressed and maybe shifted to some extent. So, one of the things that we really do like to differentiate when talking about post-traumatic stress disorder, the word trauma gets thrown around a lot nowadays, right? Like people are getting traumatized, all over the place. And we really do want to be clear that when we're talking about post-traumatic stress disorder, we are talking about a very severe or serious threshold of exposure, right? We're talking about either direct or indirect exposure to things like war, combat situations, threat of or actual physical violence, sexual violence, natural disasters, floods, pandemics, and all the incumbent stresses that come with that. Or threat of harm or death to either yourself or to a loved one, right? So, like for instance, while we can understand that, let's say, going through a divorce is highly, highly stressful, for many or most people, we wouldn't necessarily consider divorce to meet that threshold of what actually is considered to be a criterion A stressor, like a type of potentially psychologically traumatic event that could lead to the onset of symptoms of PTSD. For sure, going through a very difficult and adversarial divorce, for sure that is, stressful and upsetting and can have a psychological impact, but we really want to be clear and reserve the threshold for criterion A stressor for these types of direct or indirect exposures, right? We'll also throw into this mix, and this is new in the DSM-5 diagnostic criteria, repetitive exposure to the adverse components of a traumatic event. That also can be considered a threshold event. So talking about people who do, let's say, child sexual abuse investigations, or I've done some work with Crown prosecutors who have to sort of repeatedly review photographic evidence and hear, videotaped recordings and so on and so forth. The repetitive exposure to details of traumatic events, that also can sort of tip us into that threshold that could lead to the onset of symptoms of PTSD, okay? So we are talking about serious, threatening, life or other threatening types of events when we're talking about the type of trauma that can lead to the onset of PTSD symptoms, okay? So assuming we've met that threshold, there's been some sort of a criterion A exposure, it really does meet that threshold of severity. The person, felt a sense of helplessness. They thought they were going to die, or they, were in the presence of someone who's dying in front of them. They couldn't do anything. So all the helplessness incumbent in that, right? Assuming we've met that threshold, we then are going to look for and assume from a diagnostic perspective that we are going to see symptoms develop across 4 predictable symptom domains, okay? One of them is that we're going to see what are called intrusion symptoms, okay? So after a traumatic event, the person starts to have nightmares. They start to have what are called intrusive thoughts, or sort of involuntary thoughts that kind of come unbidden into consciousness about the traumatic event, right? So I'm reading a book or trying to do some work, and all of a sudden, boom, I've got this memory of something that happened related to this trauma, okay? So we're going to anticipate that intrusion symptoms, so intrusive thoughts, nightmares, that if the person is confronted with some sort of a reminder of the traumatic event, right, they get a smell in the air type of thing, there's going to be this whole physiological response that occurs, and typically that's going to be accompanied by significant emotional distress, where the person feels, fearful, terrified, angry, whatever the experience may be. So the point being that the trauma, the traumatic event, the unprocessed traumatic event begins to intrude into consciousness, and that really disrupts and interferes with the person's ability to function, okay? We're going to need to see one of those types of intrusion symptoms. We'll also put into intrusion symptoms so-called flashbacks, or what we call dissociative recollections. Flashbacks from an epidemiological perspective are actually relatively rare. So we'll oftentimes hear people talk about flashbacks, but when you explore them a little bit more in depth, what's happening is that they're having intrusive thoughts. So with a flashback, the person is truly like transported back to the moment that the trauma was happening, meaning they're no longer oriented to time and space. They are back there actually as if the traumatic event was happening again, right? An intrusive thought can be absolutely overwhelming and really absorbing, but the person is still oriented to time and place, right? And it's important for us to differentiate that for people because, again, a flashback is relatively rare, generally speaking, and we want them to understand that a flashback is not an intrusion. An intrusion is not necessarily a flashback. It actually helps them to really understand the types of symptoms that they are having, right? Because with an intrusive thought, we can sort of ground ourselves in the fact that we are still in the present moment, okay? So one of these intrusion symptoms we're going to want to see. Then we look at the avoidance symptoms, okay? Avoidance is interesting in post-traumatic stress disorder because it is both a symptom, but it also can become a coping strategy, right? So really common for people, and this is one of the things that we see that can interfere with the natural process of recovery, really common for people to start to develop patterns of avoidance to cope with the intrusion symptoms and the reactivity that they're having, right? I just won't go to that intersection. I'll just avoid that part of the city. I won't go into crowds. That'll be part of how I keep myself safe, keep myself regulated, right? Avoidance from a symptom perspective means that, when memories come up, when physiological reactions come up, when emotions emerge, the person goes, ugh, I don't want to think about it. I don't want to feel about it. I'm going to push it away. I'm going to do something, distract myself, have a drink, whatever it might be. But I'm going to actively try to prevent, feeling or thinking or engaging with my memories of whatever it is happened during that trauma. And similarly, like I already mentioned, we're going to see all this behavioral avoidance, that the person is going to start to really sort of shrink and condense their lives because they're trying to avoid being reminded of what happened to them during that traumatic event. So in that sense, we have avoidance as a symptom and sort of a maladaptive coping behavior. Okay. Sometimes what we're also going to see is that people have tendencies towards dissociation. I'll speak to that in just a moment. From an avoidance perspective, we're going to need to see one of those types of symptoms, right? So some way that the person is starting to avoid their experience after the trauma has happened. Negative alterations to cognition and mood. Typically people after a traumatic event, they're going to blame themselves. They're going to have a very exaggerated sense of danger in the world. They may feel detached and cut off from other people. Their mood typically diminishes. They may have difficulty remembering aspects of the traumatic event. Okay, so there's a number of ways in which post-exposure, the person's mood and cognition starts to shift. And we're going to need to see two of those types of symptoms. And then finally, the fourth symptom clusters are alterations in arousal and reactivity, meaning the person's having a hard time relaxing, they're having a hard time focusing attention and concentrating, there's sleep disruption, typically there's greater anger and irritability, the person has a harder time relaxing, they may be engaging in sort of self-destructive behavior like more road rage, driving recklessly, substance abuse, things like that. Okay. Now, sometimes we do see a dissociative subtype of PTSD where the person will have these symptoms that I'm describing, and they have this proneness to either depersonalizing or derealizing, meaning they sort of become separate either from their body or from their reality. And the dissociation is a type of way the body tries to cope, the mind tries to cope with the severity of symptoms that are being experienced. And we just need to know that that is a potential subtype that people could experience. Okay, now I'm just going to put here some other common terms that you're going to hear, and I've just put a link for the glossary of terms that CIPSRT has developed, because I think these are other terms that are really important for us to understand, because they are used oftentimes and frequently or regularly when we're talking about post-traumatic stress disorder and PSP and so on and so forth. High level, and I'm not going to go through all these just for the matter of time, so I would really encourage you to review the glossary, and there's a ton of other terms in the glossary that can be helpful for us to know about. But operational stress injury, okay? So post-traumatic stress disorder is potentially an operational stress injury, okay? So OSI, operational stress injury, is a term that was developed actually in the Canadian military by Lieutenant Stefan Grenier is his name, and the idea and the intent behind the term operational stress injury was really to work at destigmatizing the diagnosis of post-traumatic stress disorder and other psychological conditions, particularly in the post-Afghanistan landscape when Canadian soldiers were returning with way higher rates of diagnosed PTSD than had been previously seen before. So the idea of operational stress injury is that the person has sustained a psychological injury secondary to their operational duties or to the service that they've given to their country or their community. Okay, so an operational stress injury can be post-traumatic stress disorder, but it can also be other mental health conditions. So depression can be an OSI, other anxiety conditions can be an OSI, substance abuse could be an OSI, and PTSD would be one of those. Okay, so we don't want to use PTSD and OSI interchangeably, meaning that they're the same thing. We want to understand that PTSD is a type of operational stress injury. Okay, and post-traumatic stress injury, I'm going to speak here just really high level about trauma in the brain here in a moment, but we are also shifting away from disorder and more towards injury, again from the perspective of we actually have some good neurobiological research nowadays that does support the idea that this is an injury that the person has acquired, and when we're talking about an injury, we're talking about something that potentially has a bit more hope for PSP, right? And for other people diagnosed with PTSD. If we've sustained an injury is something you can heal from. An injury is something that you can put some interventions into place and be able to recover and get to the other side, right? When we're disordered, that really, potentially can be personally pejorative and make us feel deficient or weak, or something's wrong with us, whereas an injury can be something that we've sustained and we can do something to heal from. Okay. Sanctuary trauma is just this notion that it's actually not on the glossary. It'll probably be in the next version, but it's a term that's out there now, really speaking to this idea that, around that organizational stressor component, if people feel like they go out on the front line and they do what they have to do and they have all this exposure and difficulty, but then they come back to the detachment or the hall or whatever, and they're met with invalidating social responses, or they're criticized or rejected for the struggles that they're having, the place that they're supposed to seek sanctuary now becomes part and parcel of how they've experienced trauma, right? So sanctuary trauma really meaning it's the sanctuary, the work environment, the family that people believe they're sort of part of, that actually can contribute to them feeling rejected, dismissed, invalidated, unrecognized, whatever the case may be. Okay, so in terms of the others, these are just some ideas: vicarious trauma, burnout, compassion fatigue, really important terms for us to understand. So I would direct you to the glossary just to do a deeper dive into those, and you might find other terms that are relevant or useful. Okay, so again, I'm going to go really, really high level into how does PTSD develop and the physiology of operational stress. Okay, again, I'm happy to provide some references for this if this would be helpful for folks. This is a really high level introduction, but I think it is important for any of us who are working with PSP or supporting PSP, if we might be in management or leadership roles, to understand, and also just to understand for ourselves, right? That, we all have a nervous system. Our nervous systems are driven by two principles, right? One is make sure that we survive so that our species can pass along its, DNA and genetic material to the next generation so our species can propagate. And one of the ways we accomplish that is by keeping everything in homeostatic balance, right? All of us right now, if we're feeling well and doing well, our body temperatures are going to be about the same. We're going to have hopefully a generally speaking balance between oxygen and CO2 in our bloodstream. The acidity and alkalineness of our urine, etc. So point being, we have all of these mechanisms within our body to keep us within homeostatic balance, and that's the way that our bodies thrive and like to exist. Okay, our brains are basically sorted into crudely three sort of sections. The lower part of our brain really motivated towards survival. The midbrain is where our limbic or our stress response mechanisms are housed, and the midbrain structures are really involved in the expression and regulation of emotion. And then we have this prefrontal cortical part of our brain that is there and developed most recently in our human species, that helps us with evaluation and analysis and making sense out of things, and really doing higher order cognitive processes after events occur. Okay, within the limbic system, we have the autonomic nervous system, which is into two branches, the sympathetic and the parasympathetic. These two systems are supposed to work in nice balance with one another. So I'm sure we're all familiar with the idea of fight and flight and freeze and flop. I'm not going to go into those terms significantly today, just because of certainly because of time. Okay, but just to know that when a stressor or a threat happens, the limbic response to stress is for our autonomic nervous system to get activated and for us to have this whole suite of physiological and cognitive and emotional changes mediated by the sympathetic nervous system. And it really is to mobilize us to run away or fight off, but somehow do what we need to do to survive whatever that threat to our survival could be. And then after that happens, the parasympathetic nervous system is intended to come in to help us to rest and digest and come back down to homeostatic baseline. Okay, really important for us to understand that when we are in the throes of coping with a traumatic event, the prefrontal cortical structures basically go offline. The blood flow and the activity that is happening in our brain at the time of a critical incident is really going to that limbic system. It's really going to help sustain the energy and the deployment of resources from limbic structures that need to help us to respond and survive whatever it is that's occurring. Okay, one of the things that we've come to understand, kind of two key principles as it pertains to post-traumatic stress disorder, okay, or post-traumatic stress injury. One is that as a species, we seem to have done ourselves a little bit of a disservice because we've gotten to be very smart, right? Which is we seem to be able to turn this stress response on for purely psychological reasons. There's a really, really great researcher out there. His name is Robert Sapolsky, and he's written a book and done podcasts on, it's called Why Zebras Don't Get Ulcers. I highly encourage you to take a look at it if you get a chance. But he really speaks to this in detail, that, you know, it's the stress response now seems to be very vulnerable to ways that it's getting turned on and left on for reasons that it was not designed for, right? The stress response, when it occurs, is a very, very powerful response. It's intended to help us to survive, but it's not intended to be turned on and left on, because it's actually a fairly toxic response to our body as a whole, okay? Our amygdala, the sort of, you know, go, no go part of that stress response, it secretes a ton of glucocorticoid into the limbic system when it gets activated, which is great for short term. We need that. But over the long term, that can actually become really, really toxic to other structures in that limbic area. So, you know, when we speak about post-traumatic stress injury, one of the things that we understand can happen for people who actually then develop symptoms of PTSD and have sustained that injury is there's some predictable changes that can happen to those brains and nervous systems. One of which is in the brains of people diagnosed with PTSD, oftentimes what we see is greater than expected volume of amygdala tissue, because that amygdala is just working and it's growing and it's sort of expanding in volume because it's always turned on. And because of some of the glucocorticoids and the toxic nature of that that's being secreted into those midbrain structures, the hippocampus, which is a part of the brain that is there to help regulate emotion and help us keep track of memories in an effective way, these actually, the hippocampal tissue actually starts to be sort of destroyed by all of that glucocorticoid. So what we have in the brains of someone with PTSD is bigger than typical amygdala, shrinking or shrunk hippocampal volume. And what we see is that over time, the connectivity between the limbic structures and those prefrontal cortical structures actually goes sort of more permanently offline. So in someone who's injured in this way, we actually see that those midbrain structures start to be kind of the ones in charge, which is why we then see triggered reactions and a lot of anger and reactivity and the intrusive symptoms that I spoke to earlier. So again, that's a really high level introduction to sort of what's happening physiologically with PTSD, but I really think it's important for us to understand we do have some neuroanatomical correlates to PTSD, and again, that's why we feel more comfortable using PTSI, because it's like, no, actually there's like legitimate physiological and biological changes that are happening for people when they've had the onset of symptoms of a PTSI. Okay. I'm just seeing that question. The name of the book author is Robert Sapolsky, and it's Why Zebras Don't Get Ulcers, is either the podcast or the book. From a treatment perspective, there are definitely multiple ways that people approach treatment. This is a staged approach to trauma treatment that came from a woman named Judith Herman, who proposed this kind of triphasic model of trauma treatment, where we might want to see a period of stabilization where we're really looking at skill building, right? And if someone comes in for treatment, they're experiencing symptoms of post-traumatic stress disorder, we want to look at, do you know about sleep hygiene? Do you have ways that you're trying to focus on slowing your nervous system down, like doing mindfulness meditation? Do you have ways that you cope with distress, right? Like, so even some dialectical behavior therapy kinds of skills can be taught. And can be helpful for people to feel like when I'm triggered or when I'm anxious or when I'm struggling or distressed, I can do these things to try to take care of myself or facilitate greater coping or greater regulation, okay? So, on the front end of treatment, after we've done our assessment and we know what we're working with diagnostically speaking, we do sort of want there to be a period of skill building stabilization to make sure that the person has a bit of an inventory built up so that they can take care of themselves, hopefully more effectively, which becomes relevant when we then move into active trauma processing, right? We want somebody who's coming into like my office to work on their traumas, we want them to have some things they can do to take care of themselves outside of the time when they're in treatment or in the therapy office, okay? And we're gonna do active trauma processing for as long as we need to achieve our results, right? Which could be symptom reduction, it could be improved functioning, it could be improved reported quality of life, right? There's lots of ways that we track progress from a trauma processing perspective, but that's gonna be oftentimes with PSP where we're gonna be spending a significant amount of our time, right? And then, after that, it's kind of looking at, okay, well, what's left over from a relapse prevention and other factors standpoint? Are we helping the person reintegrate back to work? Are there relationship issues they need to deal with? What are the other things that have maybe been lingering or outstanding for them that we now need to turn our attention to? I like to say, like, if you go and look for, what are treatments for PTSD or treatments for trauma, there is a laundry list of treatments out there. And I think there's probably treatments that I haven't listed on this particular slide that are effective. Accelerated resolution therapy would be a treatment that I potentially, might include into this list because it's got a building evidence base to support its effectiveness. What I included here was the APA guidelines, the American Psychological Association guidelines published in 2020, which are sort of their recommendations around evidence-based therapies. So from an APA perspective, prolonged exposure, cognitive processing therapy, cognitive behavioral therapy with exposure, and stress inoculation therapy. These would be some of the therapies that have, again, randomized controlled trials and repetitive results of effectiveness, okay? That's not to say, as I said, like EMDR, they put it under conditional evidence. I use EMDR in my practice. I have a lot of really good success with it. So this is not meaning to say that one is necessarily better or worse than the other, but we're just looking strictly from an evidence-based perspective. And so from an evidence-based perspective, PE and CPT and the other CBT sort of interventions, they have the strongest evidence base. Again, we could have a whole debate about why that might be. And certainly EMDR would be in there in the list. And, there's somatic experiencing therapies. There's, as I said, accelerated resolution therapies. There are other therapies. What we want to really make sure when we're looking at treatment of PTSD is that the intervention is in some way supporting the individual to engage in processing their thoughts, their feelings, their memories, their cognitions, their body reactions to the trauma that they went through or the traumas that they went through. That natural process of recovery that I've been referencing, that is about engaging, processing, actually getting the prefrontal cortical structures back online to make meaning out of the experience and to really be able to experientially work through what it was that the person experienced at the time that the trauma happened. So, PE, CPT, CBT with exposure, EMDR, they all come at this same target just from different, ways or perspectives. So that's one of the things. I'm trained in all of these therapies, and that's one of the things that I know is the core of it, right? Is that we have to find, ways for people to safely experience and confront what they went through during the time of the trauma or traumas that have led to the onset of symptoms in a way that they can learn something new about the experience and be able to put that prefrontal cortical stamp on the experience where they're able to make some meaning out of it. They're able to think through and have a perspective on what happened, where the memory becomes organized and easier to digest, okay? And so I just put this in, again, emerging therapies with a growing evidence-based, so art, narrative therapy, there's lots of talk about psychedelic therapies out in the marketplace nowadays, so we'll see in the next 3, 5, 10 years what happens with that. I'm part of a psychedelic training program right now, and certainly the thinking is that MDMA for the treatment of PTSD will be a prescribable medication within the next probably 3 to 4 years. So I put that out there, right, because that's going to be a whole other area for clinicians to potentially need to learn about or gain some competency around. Okay, so I know I've got like 3 minutes left, so this is going to go pretty quickly. How to recognize PTSD in other people, right? It's tough because oftentimes what we are really looking at is more of an erosion over time versus a light switch, right? Like it's not typical that you're going to see someone one day like this and then the next day completely changed. It's more of change over time that we're looking for. And so, in your organizations, having peer support programs, having regular opportunities to interact with one another, these are important ways of keeping an eye on each other's mental health, okay? Personality changes, though, are pretty significant, right? So somebody who, used to be pretty easy to get along with, and now increasingly they're not going out for those coffees. They're wanting to be by themselves. You hear stories of ways in which they're withdrawing. People who are really much more reactive, right? Like they are quick to leap to a negative interpretation and get, furiously angry really, really quickly. Somebody who maybe used to be really stoic is now sort of easily ruffled or thin-skinned, kind of relative to a fairly minor provocation. The strong reaction to diagnosis in other people, right? I see this time and again that when somebody's like, oh my God, that person's off work for PTSD, like they're milking the system, that doesn't exist, da, da, da. To me, that's actually a bit of a flag where I go, okay, what's that touching on in you that you're having that powerful reaction to someone else, right? Definitely increased substance use, increased work behavior, right? Sometimes we see people who, they're just wired for sound, they're super hyper aroused, they're not sleeping well, and so they just want to work and work and work and work. And it's tough, right? Because that could be a person who's seen as a high flyer, but actually that can sometimes be a bit of a worrisome sign of like, you know, what would happen to this person if they actually slowed down and stopped, right? Other compulsive behavior changes, right? Like we definitely know that people have greater risk of getting into, you know, gambling patterns or sex addiction types of patterns, right? Like behaviors that serve as a degree of escapism or a degree of sort of a maladaptive way of trying to regulate emotion, right? So these are the kinds of things we want to be on the lookout for. I mean, obviously, if somebody's talking about, I'm having more nightmares, I'm having more memories of this thing, I can't go, you know, I can't go to work because I can't handle, you know, hearing the tones. You know, those are obvious signs, right? But this list that I've given you here is just, you know, these are some of the more nuanced things that we want to keep an eye out and look for. And then some common PTSD myths, right? That there's no recovery from PTSD. You know, I always talk about this like a serious injury, right? Like if I were to break my back, it would be understandable that I would need to have a period of treatment intervention, probably a lengthy period of rehab in order to reclaim my functioning. And that probably moving forward in my life, there would have to be things that I would do to tend to the injury I sustained, like stretching every day or maybe going to physio, but I would be able to recover. I really like us to think about PTSD in that way, right? Can we take away trauma and what that has done or impacted the person after it's happened? No, of course not, right? But somebody actually can go into remission from symptoms of PTSD, and they can also learn to live differently with the traumatic event that occurred, okay? PTSD doesn't exist. It's a sign of being not up to the job, right? We really need to do away with that. That is an old, historical, really unhelpful perspective that contributes to the further sort of stigmatization. There's some research coming out of Kingston in the near future with a population of police officers saying that like up to 40% of people are still saying they fear the stigma of coming forward with an operational stress injury within their work environment, right? And it's because of myths like that, right? PTSD only develops right after an event happens. We actually know that there can be delayed onset of PTSD. My first PTSD patient in the VA in the US many, many years ago was a woman who had been sexually assaulted during the Korean War. When I started working with her, she was 83, right? And it had only been once she went under surgery the year before that she'd had this kind of destabilizing experience, and all of these intrusive memories of her sexual assault had come back. So we absolutely know there can be delayed onset of symptoms. Only military get PTSD. I hear this lots, right? Like, I don't deserve this diagnosis because I'm not actually, you know, I'm not going to war. I'm working in my community. No, right? We actually know that for frontline PSP, police officers, firefighters, corrections, whatever, I mean, again, hundreds of exposures, and the challenge there is that those exposures are happening within the communities in which people are living. And so there really is no ability to get away from the persistence or the potential for that threat, right? So PTSD is a very legitimate and very real diagnosis and condition that frontline PSP can experience. And, you know, people diagnosed with PTSD are dangerous, right? You know, I know that unfortunately sometimes there are these high profile media events where somebody has done something dangerous or violent and they happen to be diagnosed with PTSD. We need to understand that, you know, again, epidemiologically, that is a really, really, really rare likelihood. People with PTSD are harder on themselves and much more likely to be destructive to themselves than they are likely to do so for other people. Okay, so I think I did it. Okay, I'm 2 minutes over. There's my email. Please, you know, take a screenshot. I'm happy for you to engage with me. I'm always happy to have questions, but I'm going to stop now and take whatever questions people might have for me right now.
Thank you so much, okay, Megan, for your presentation. I'll start with the first question, and that is just a request if you could go through the difference between vicarious trauma and compassion fatigue, as there's lots of literature suggesting they're the same, but that's not been the questioner's experience.
Yeah, so vicarious trauma or secondary traumatization sometimes is this notion that I think of this like particularly in a family system, right? So we know that like spouses and children living with somebody who has been diagnosed with PTSD, oftentimes they are experiencing vicarious trauma. Some of that being just the absorption of, you know, living with somebody who is reactive, you know, dysregulated from a nervous system perspective, potentially doing things that are really difficult to sort of observe or be part of. and maybe even sharing potentially details of their traumas. So that can be sort of a vicarious or secondary traumatization, where it's not necessarily happening directly to you, but you are in the environment and you are being impacted by that person who is diagnosed with a direct post-traumatic stress disorder, right? We see this also in like support staff in PSP organizations, right? We actually know that people working in support positions within police departments or fire stations, they actually have a much higher potential for vicarious traumatization, burnout, than folks who are working in non-PSP organizations. And again, it's sort of this absorption contagion factor of being in an organizational environment where you're sort of perpetually exposed to or experiencing the effects of a traumatized workforce, okay? Compassion fatigue is slightly different. I don't believe that they're one and the same. We have to understand that compassion within us is a really important capacity that we have as human beings, right? One of the ways that human civilization has, developed and thrived, challenging to say that at this moment in history, but whatever, is through our ability to come together in community, right? We seem to have survived. I mean, we're not really great at fighting off predators. We're not really great at eating and hunting things, but we have been able to come together and be smart about it and learn how to work in communal ways to advance our species, right? Compassion is a huge part of that, right? Being able to understand and connect and feel sympathy and have an emotional reaction to the people who are around us. And the thing about compassion is that it's a really necessary variable for those sort of communal relationships, but we don't have an endless amount of it. And so compassion fatigue, if we think about frontline PSP or people working in helping professions, right? The notion there is that we actually can run out if we're not engaging in restorative activities that allow us to kind of shore up or take a break or get off the front line for a period of time, so we can kind of tend to sort of restoring or rebuilding our own stores within ourselves. We can and we will run out, right? And when we get to a place of compassion fatigue, typically we report feeling emotionally exhausted, feeling like we just don't have the care to give anymore, feeling easily irritated by the needs of other people, feeling really overburdened by responsibility. So slightly different feelings. With vicarious trauma, people can actually develop symptoms of PTSD related to the indirect sort of experience or contagion they're having in that environment. Compassion fatigue really is more of a wearing away or a depleting kind of an experience within us.
So another question is, if a member is still working on mindfulness 4 years into therapy, is that a red flag?
They can absolutely be working on mindfulness if it's part and parcel of something else, right? So like, folks that I work with, it's like the front-end stabilization skill building stuff, that doesn't end. That's not like a discrete period where it's like, okay, you've learned to do this, now you're good. I really talk about that work particularly as part of lifestyle change, right? So again, a physical health example would be if somebody had a heart attack and they required, triple bypass surgery, and they didn't make any lifestyle changes. They didn't start exercising more, quit smoking or whatever. We would be worried about the risk for a future heart attack in the future. The skill building aspect of PTSD treatment is somewhat similar, right? We need people to develop different self-care practices, different emotion regulation and mindfulness kinds of behaviors and habits. And those need to be skills and behaviors that they continue, right? Because especially for people who are going back to working on the front line, further exposure is going to happen. And so we need them to have this repertoire of skills that they build up and that they continue. So if somebody's 4 years into treatment and they're still doing mindfulness, fantastic. But are they doing something else, right? At some point in time, we do need to go, okay, we've got enough skills in place here. It's now time for us to go into processing trauma, because really, when we think about what's going to have the greatest bang for the buck in terms of somebody's recovery and ability to go back to work, etc., it's going to be in processing and working through the traumatic events that they've experienced. So if somebody's only doing mindfulness and they have a diagnosis of PTSD, yeah, I'd be a bit worried about that. I'd be going, why aren't you sort of getting into more of a trauma-focused type of an approach? Is it because the practitioner's not certain how to do that? Like, what's the issue? Because mindfulness in and of itself is not going to be sufficient. It's not going to be sufficient in and of itself to reduce the symptoms of PTSD.
Can you please comment further on sanctuary trauma? I deal with those that have been traumatized by therapists who claim to be able to deal with first responder issues, but in fact aren't, and end up doing great damage in the process.
Oh man, thank you for that question and for bringing that up. I think, us at CIPSRT, we talk all the time about cultural competency and like how do we really try to bring more therapists and clinicians up to the sort of threshold of understanding the work of frontline PSP, because yes, right, like if somebody really doesn't understand the work of first responders, public safety personnel, there absolutely is that risk. So sanctuary trauma, I mean, for sure, like the notion that you're going to seek help from a helping professional and that person actually maybe intensifies or contributes to the mental health difficulties you've had, that would absolutely fall within that realm of sanctuary trauma. We think about sanctuary trauma definitely from an organizational perspective. So a very common story from frontline PSP is like, I did X, Y, and Z thing in the service of my organization. And, when I started into this career, I was really sort of told that this was a family and we were going to look out for one another and stand shoulder to shoulder. And then when I started to struggle, actually the opposite happened. I went off work and I never heard from anyone again. Or I was, sort of specifically told by my supervisor, well, this is the job. If you can't, if this is how you're doing, maybe you should think about doing something else. Or, being put off work because they're seen to be too fragile or what have you, right? There's lots of ways that sanctuary trauma can occur. It's just that we have to understand that it's where you're trying to seek safety, right? Where someone feels like they can go and just drop the armor and feel safe and feel like they can do that restorative work that we're talking about, but that sanctuary that they're counting on ends up being actually full of sharks, right? That's what we're really talking about and thinking about. And so, yeah, from a clinical perspective and with therapists, I can for sure tell you that CIPSRT and the clinical subcommittee, I mean, we're actively working on how do we try to have more protections in place and more information available to frontline PSP so that they can make sure that the person that they're sitting down, across from to receive that help and to find that sanctuary actually is safe and able to do the work, right? We're certainly not there, but efforts are being made, and it is absolutely an issue that I think people are alive to. So again, I just want to thank you for bringing that up and highlighting that risk.
Okay. So another question is, can moral injury lead to PTSI or PTSD? And how does it differ from sanctuary trauma, or are they connected?
I would say they're connected for sure. I would also say that they're different. So yeah, I mean, a morally injurious kind of an experience, oftentimes, like let's say, pediatric fatalities oftentimes kind of have that morally injurious aspect to it. Certainly like bad things happening to good people or people doing bad things and getting away with it, right? Those are kind of like morally injurious types of things that we think about. When children die, that's outside of the natural order. That's not supposed to happen. And like, particularly if a child dies secondary to being neglected or not being cared for properly by their caregivers, like that's a really morally injurious thing that PSP confront and face, right? That shouldn't happen. That's outside of the natural order, right? Those go against our moral code. And so for sure, right, a morally injurious event is oftentimes a traumatic stressor, right? Like I'm talking about a pediatric fatality, that would 100% meet that threshold of criterion A exposure. And so for sure, a morally injurious event could absolutely have influence. That could absolutely be a stressor that could lead to the onset of PTSI symptoms. And, I would say that moral injury and sanctuary trauma are connected. They're not one and the same, but they're definitely connected, right? So like, if I come back to the hall, destroyed and like maybe, feeling really vulnerable and maybe outwardly expressing some emotion, and I get the hell's wrong with you? Go somewhere else. You know what I mean? Like that's sanctuary trauma, and that potentially also could be experienced as morally injurious, because it's like, what are you talking about? You're supposed to be my person. You're supposed to be there with me, and that's how you treat me. So I'm sort of horrified and rejected and like stunned by the fact that happened. But then how do I make sense out of that? Like, you're supposed to be the person who is, my peer and my support, and this is the response that you got. So again, different, but for sure overlapping or interrelated.
Okay. So the next one is, what do you suggest for someone who has suffered and is being treated for PTSI by a counselor and meds, but 2 years later is still being triggered by the event? What treatment modality would you suggest next?
I might need just a little bit more information. So I would really want to know, sometimes what can happen, and this can happen to me, it can happen to lots of, really experienced clinicians. It can also happen, from clients themselves, is that, sometimes people are pretty good at, actually maintaining a degree of avoidance, even though it appears as though they really are doing the work that they're supposed to. So I would want to know more about what is the actual treatment intervention that's being offered, and how do we know, like, what are our markers that the person is actually really emotionally engaging with whatever the index traumatic event is, whatever therapy they're using, PE, CPT, EMDR, whatever it is. We need to have confidence that whatever intervention we're offering, the person actually truly is emotionally and cognitively engaging with that process, right? And it can for sure happen that sometimes, like even in PE, people can have their eyes closed and telling the event, but actually there's like a dual attention going on where they're telling the story, but they're actually not super emotionally engaging in it. So I would just want to clarify that piece of it before moving on to the next treatment modality. I would also want to make sure, does the person have a behavioral exposure program that they're following? Are they doing in vivo exposure? Are they going to where the incident happened, and are they doing that in a supported kind of a way? Because those two pieces really do need to come together. I appreciate an approach that has a lot of behavioral components to it, because oftentimes we learn best through doing, right? Sometimes trying to talk ourselves into thinking about something differently isn't, 100% effective. But when we see ourselves doing something differently and having a different experience than we thought we were going to, some pretty powerful learnings can take place there. So all that to say, before moving on, just make sure that that emotional engagement is happening, and make sure that there's a really comprehensive way that the person is going after processing whatever the index trauma was that they've come to receive treatment for.
Okay, wonderful. So I'm going to leave it there for the questions. Thank you so much, Dr. McElheran, and to everyone in the audience for this great session. This town hall is the final event in our PTSD Awareness Month activities before June 27th, which is PTSD Awareness Day, and we hope you will join CIPSRT in wearing teal to support PTSD awareness and get stigma out and understanding in. There will be a quick survey at the end of the town hall. We hope you'll take a moment to complete it. This is our last town hall for the summer as well, but we will return with a new event in September. Please keep an eye on our website and social media for more information. Once again, thank you all for being here, and Dr. McElheran, thank you so much for your expertise and sharing that with us today.
My pleasure. Thanks everyone for having me. Thanks, Emily.
Bye.
Bye.